Dr. Dunne is going to share now, and you'll have an opportunity to ask her some questions at the end of her presentation as well. And so Dr. Dunne is co-clinical director and reproductive endocrinologist at PCRM. We're so grateful and excited that you're able to join us today. Thank you so much. So without further ado, I will pass it over to you.
Thank you so much, Alda. So what I was asked to talk about today was, in general, just fertility 101, fertility awareness, and how the pandemic has affected fertility as well. So I thought I would frame it in terms of some facts and busting some myths. So for those of you who have been through fertility treatment, I'm sorry if some of this is a little bit basic, but I really wanted to cover something for all audiences. So we'll talk about why fertility is important. We'll go over some of the basics. We'll go over some of the most commonly held myths and get the facts around those things. And then I'll talk to you a little bit about the COVID-19 vaccine. And I hope that this will take 20 minutes. Okay. So why talk about fertility? It's important because women in our society are choosing to have children later in life. And if you look at Statistics Canada, 2010 was the first time that more women in their 30s were having children than women in their 20s. So that's quite profound when you consider that for hundreds or thousands of years of evolution, women were having children predominantly in their 20s. And then in one generation, there's been a shift now predominantly to women having children in their 30s. And interestingly, British Columbia has the highest age of first birth in the country, followed shortly after that by Ontario. So these are stats from British Columbia. And really what I'm using them to demonstrate here is just that you can see the area of women over 35 here. And they are increasing in the age of birth as time goes on. And then this is the 20 to 34-year-old age category, and those numbers are going down. So the most recently available statistics demonstrate here that you can see the large majority of births now are happening in women over the age of 30. So just about 60%. And the second point is that infertility is prevalent. I don't have to tell this audience, but infertility affects 1 in 6 couples of reproductive age. And unfortunately, infertility is associated in society with stigma and with shame, and sometimes that means that people don't talk about it openly. But there have been instances, I'm sure you're aware of some of these in the media lately, where celebrities are coming out and sharing their stories. And as our women from the panel today know, that takes a lot of bravery. So we know that Chrissy Teigen has suffered with infertility and infant loss. Jimmy Fallon, Mark Zuckerberg, both with miscarriage, Kim Kardashian with infertility IVF, gestational carrier, Brooke Shields as well. So just to name a few, I think the conversation is getting more commonplace in our society, but we're still not where we'd like to be. So let's talk about some of the basics. Number one is egg quality. So I feel healthy, so I don't have to worry about my eggs, right? And this is something that I do hear from patients, especially now we're very focused on things like our health and our fitness. But unfortunately, despite how healthy you are, the best predictor of egg quality is age. And that's been true for thousands of years over many hundreds of women. And the reason for that is because women are born with all of their eggs, as opposed to men who get to make new sperm every 70 days. A woman is born with about 1 million eggs. And by the time she hits puberty, a female has about 300,000 eggs left. And then every month, there's a group of eggs. And those of you who have come to the clinic have probably had an antral follicle count, or AFC. And you can see in this middle picture here, that's what we're looking at, are just these little follicles in the ovary. And each one of these contains an egg. And that is the group of follicles that theoretically is going to compete against one another during the month. Only one will ovulate, and then the rest of the group dies, and then the whole process repeats itself. So that's how we lose 10 or 20 or 30 or more eggs every month throughout our lives. And that's also why, for example, when we do IVF or when we do egg freezing, we're taking out these eggs that were going to die anyways. So IVF isn't advancing your path to menopause or causing you to, waste your eggs or lose your eggs early. The second myth is that it's easy to get pregnant. I heard some of the women say something similar, which is that because reproduction is natural, many of us think it must be easy. But that unfortunately is not the case. Even when a couple is in their 20s, the maximum odds of pregnancy every month are about 20 to 30%. So what I hear from many of my patients is that they spent their whole lives trying not to be pregnant, and now they're trying to be pregnant and they can't believe that it's this difficult. So keeping in mind, when we talk about the success rates of various treatments, whether they are IUI or IVF, we're not going from 100% down to whatever that success rate is, down to 10% or 20%. The maximum chances that somebody has in a month naturally anyway are 20 to 30%, and that's under the best circumstances. So how to tell when you're ovulating? My favorite method would be ovulation predictor kits. These kits are designed to detect a hormone in your blood called LH, or luteinizing hormone. So what's happening at the level of the ovary is that in the beginning of the month, you have an egg that's developing, and the little cells around the egg are making estrogen. Eventually, when the egg is ready, the brain knows that the egg is ready because the estrogen has been sustained at a high level for a couple of days, usually about 48 to 52 hours. And then the brain sends a big signal in the form of luteinizing hormone. And this surge can last anywhere from 12 to 40 hours. Generally, it's detectable in the urine during that time, but some women will find that their LH surge is a little bit more difficult to detect. But when this surge of hormone comes from the brain, it causes the egg to pop out. And then after the egg pops out, that little structure that's left over is called the corpus luteum, and that makes progesterone. So when you look at this graph, what you can see is progesterone is only made after ovulation. At this initial stage of the cycle, this first half of the cycle, there shouldn't be any progesterone present. So if you are measuring things like the progesterone level in your blood or even the estrogen level in your blood, keep in mind that at the beginning of the cycle, both of those numbers, the estrogen and the progesterone, should be essentially zero or very, very low. And then estrogen rises throughout the cycle as the egg grows, and progesterone is only present in the second half of the cycle. Now, the egg only lasts at its prime for fertilization for about 12 hours, whereas the sperm can last inside the body for about 3 to 5 days. So in our business, what we like to say is the sperm has to be waiting for the egg. So that's why the fertile window is considered to be the 6 days up to and including ovulation day. Once the egg pops out, your fertility drops significantly. So having intercourse or doing a treatment like IUI in the 1 or 2 or 3 or 4 or 5 or 6 days up to and including ovulation are going to give the best chances of pregnancy. After fertilization occurs, what we can see in the lab is that we have 2 little structures here called pronuclei. One comes from the female and one comes from the sperm or the male. And this is actually a picture taken in our lab. This ring around the outside that you see here is the shell of the egg. The scientific word for that is the zona pellucida. And then inside here, you have the genetic material from the egg, which is the first pronuclei, and then the second from the sperm, which is the second pronucleus. So these have not even combined yet. After that, the sperm and the egg DNA will combine and an embryo will grow. And this is time-lapse imaging taken from our lab. You can see the embryo is now 2 cells and then 4 cells. It becomes 8 cells. And then eventually you can't tell the difference between the cells. So this is about day 4 when the cells are growing at a really, really fast rate. And then here we are in day 5 where you can see the embryo is stretching and pushing and it's trying to kind of hatch out of the shell. You can even see that shell getting thinner. So that's 5 days of development captured on an embryo scope in our lab. And what a blastocyst embryo looks like on day 5 is like this. So this little tiny ball of cells here is going to make the baby. That's called the inner cell mass. And this outer rim of cells here is going to make the placenta. And what's important to see here is that all of this mechanism is still occurring within the shell of the egg, so that the egg has not hatched or cracked yet. So this is still all occurring within the egg, and this is the stage where the embryo would go back inside the body, inside the uterus. And then the arrow here is pointing to the trophectoderm, or the cells that will become the placenta, and those are what are going to hatch out and then stick to the side of the uterus. This is just a little plug because I write a lot of articles for the Huffington Post and various other publications. There's a lot of stuff online. Some of it is reliable, some of it's not. But I did write a number of articles for Huffington Post. If you just Google my name, you'll find them. Okay, so what causes infertility? Here's a myth. Infertility is always the woman's fault. Well, actually, male factors are the single #1 biggest cause of infertility. And this is something that really gets me as a doctor, because I feel like my female patients bear this disproportionate brunt of the burden for infertility. Women tend to blame themselves. They tend to feel like, as one of our panelists suggested, that this is what you're born to do and it must be easy, when in fact, the largest #1 cause of infertility is male factors. So I think in society, we blame women far too often. So, sorry for the sound there. There's actually no sound. So this is a slide showing some slow sperm. You can see in our lab. That this one on the right has lots of fast, healthy, fast-swimming sperm, whereas this one on the left is an example of male factor infertility. This guy is like pretty much lost. There's lots of dead sperm. This guy trying to get somewhere, but really not going anywhere very fast. And then once we prepare the sperm for example, IUI, we wash away the dead stuff. This is what a fast-swimming or healthy sample of sperm would look like. Okay. So in terms of male factor infertility, this is what that little slow swimming sperm might end up. So this sperm is stuck to the outside of the egg, stuck in the shell of the egg. This one is dead and also didn't penetrate through. So this sperm is trying to get through, but is just not able to get through the egg. And that's what it would look like in the lab. So what can we do to overcome that? Well, in terms of men, it's really important that men don't smoke. Smoking can have an impact on the DNA within the sperm, as well as the sperm counts themselves. Men should maintain a healthy weight because we know that estrogen is created in fat. So men who have excess body fat may have higher than optimal levels of estrogen. As well, the testes are supposed to hang away from the body, and they're supposed to be maintained at a temperature about 0.5 degrees cooler than the rest of the body. So when you are overweight as a man, there's more body fat and the testes can't hang as well far away from the body. And then finally, testosterones or other exogenous hormones like muscle supplements. Generally, if a man is taking testosterone shots, his sperm count will either be very low or it will go down to 0. When to see a doctor. So there's a myth that you have to wait a year before seeing a doctor. Well, it's true that your family doctor may tell you that infertility is after 1 year of unprotected intercourse. Technically, that is the definition. However, when a female is over age 35, we like to see that patient after 6 months of trying. And if she's over 40, we like to see that patient right away. And that's just because time at that point is valuable. So just to go over some of the basic fertility options that are out there, we're going to talk about IUI, IVF, donor sperm and donor eggs, as well as egg freezing. So starting with the most basic, IUI is also the least expensive treatment. What happens in IUI is that the sperm goes through a density gradient, meaning a gradient of different size particles, and that eliminates all of the slow spinning, all the not normally shaped sperm, and all of the rest of the ejaculate from the very, very best sperm. So you can see after the spinning in the centrifuge, the best sperm are here at the bottom of the vial. This is an effective treatment for mild sperm problems. For example, if the motility is mildly low or the count is borderline. We also often use it for unexplained infertility as a first treatment. Sometimes we use it if there are timing issues. For example, if a member of the couple is traveling out of town, sometimes there can be frozen sperm at the clinic, or sometimes the couple, for mechanical reasons, can't have penetrative intercourse. And then finally, we use it for donor sperm as well, and that can be frozen donor sperm or directed donor sperm. Essentially, after the sperm is washed, it's very simple, very similar to a pap test. We place a speculum inside the uterus, and then we use a little skinny catheter to bypass the cervix, and the very best sperm ends up in the uterus. So it's like getting best sperm in a high quote-unquote dose in the cervix, rather than what would happen normally, where the sperm would have to swim through the thick mucus in the cervix, and it might get there at various different times over a number of days. The second treatment is IVF, or in vitro fertilization, and that consists of several phases. So phase 1 is when women take injections, and those are subcutaneous injections that are like a little insulin needle that go just under the skin. That causes the body to mature many of those eggs that are available that month. And then eventually we use a small needle that goes through the top of the vagina into the ovary, and then we suck out the eggs. And the lab would separate the eggs from the fluid. IVF is effective when there's very severe sperm problems. If the woman has blocked fallopian tubes, we often use it for age-related infertility or low ovarian reserve, or for couples that have tried with unexplained infertility and been unsuccessful with other treatments, like, for example, IUI. In the lab, what we can do to overcome issues like sperm problems is we can put one sperm directly inside of a needle and inject it into the egg. And that's called ICSI, or intracytoplasmic sperm injection. So do you remember I showed you this video here of this little sperm and he can't get through the shell of the egg? Well, we would be able to overcome that in the lab by doing ICSI. So you can see the little sperm is loaded into the pipelle here. And isn't it remarkable how tiny the sperm is compared to the size of the egg? So we suck up a little bit of the ooplasm or fluid from the egg, and then the sperm's so tiny you can barely even see it come back down the needle. and then we would inject it into the center of the egg and remove the pipelle. Okay. The third treatment that I want to talk about is donor sperm. So donor sperm is increasingly popular. It's been around for over 50 years at this point. We see single women who would like to be parents on their own using donor sperm, LGBTQIA couples who lack the requisite sperm, and infertile couples, for example, those with infertility because of male factor, or couples who may carry a genetic condition that they don't want to pass on to the children. So donor sperm banks, I have no particular affiliation, but I just thought this was a good example of how you can search by physical characteristics or race, ethnicity, any type of characteristic that you think is personally important to you. And then you'll get a wealth of information about the donor. For example, pictures, genetic, medical information, medical history, sometimes personal statements, that kind of thing. Donor eggs are somewhat similar, although donor eggs, for the most part, are what we would call anonymous, or where the identity of the donor is not available. Donor eggs are becoming increasingly popular. I just wrote a review article for the British Columbia Medical Journal about this at the end of last year. And in it, I reviewed that in Canada, of all the treatment cycles in Canada, donor eggs make up about 10% or more, and that number is growing by the year. So we see LGBTQIA couples such as gay men who are using donor egg, or trans couples, and they sometimes would use that in conjunction with a gestational carrier. Infertile couples that, for maybe reasons of low ovarian reserve, premature menopause, egg quality, or failed IVF treatments, would choose donor egg as well. I always say there are lots of ways to build a family, and so I think donor egg has given hope in terms of fertility treatments in a lot of cases where there might have been no other way. And finally, egg freezing. So I am seeing couples who are choosing to delay childbearing, as well as women who have not met the right partner yet. And I should put on here that we are also seeing trans people as well freezing their eggs or freezing sperm for fertility preservation before starting or continuing with hormone therapy. Egg freezing is very, very similar to IVF. You have to do injections for about 8 to 12 days and then take the eggs out of the body, just like for IVF. It's just that we don't fertilize them with sperm. We freeze them in liquid nitrogen. And this is my second to last slide. So I added this slide because there's been a lot of interest this week about talking about COVID-19 vaccines and fertility. So I summarized on here the latest statements from the American Society for Reproductive Medicine, the Canadian Fertility Andrology Society, as well as the Alberta COVID-19 vaccination and pregnancy fact sheet. And all of these have been updated very recently. You can see the CFAS statement was April 9th. So they've all been updated like within the month. And the bottom line is that vaccines are safe and effective, and we believe that everyone, including pregnant women and those seeking to become pregnant, should get the COVID-19 vaccine. Most of the research so far, and I say most of it with a caveat there that specific research on pregnant women wasn't done in the original trials. There were some women who inadvertently conceived, so we have that data. But most of the research so far is around those vaccines made by Pfizer and Moderna that are comprised of mRNA vaccines. I think we still don't have a lot of information about the AstraZeneca Regardless, the belief is that all of those vaccines will probably be found to be acceptable for those women intending to conceive. And according to the Alberta vaccination fact sheet here, I want you to note that there's a biologically plausible benefit to breastfeeding after getting the COVID-19 vaccine, because antibodies that are made by the mom could pass into the infant and provide passive immunity. This update was from late March 2021 from the American Society for Reproductive Medicine. And for those of you who want more specific information, you can see here that there is a program in the United States called VSafe, which is a voluntary reporting program for people to report vaccine side effects. And so they've looked at women who were intending to conceive and pregnant using this self-report database. And so far, as of February, they had over 30,000 patients with pregnancies that had been reported to VSafe. And like I said, most of these women had received either the Pfizer or the Moderna vaccines. And the bottom line there is that there did not seem to be any increased risks of things like pregnancy complications or miscarriage. This is an article that I wrote for the British Columbia Medical Journal with 5 quick facts about COVID-19 and fertility in case you wanted to check that out. And I just wanted to close with 3 tips. So number 1, make plans for your fertility, particularly if you are in your 30s. Take time to love yourself and don't blame yourself. And don't be afraid to seek help. Thank you very much.
Okay, thank you so much, Dr. Dunne. That was amazing. So rich with information, super juicy. And there are a number of questions here in the chat for you that that would be wonderful if you could address. We are, we always start with a schedule, and we are running behind schedule, but I think those are really important. I think it's really special that you're here and available to answer these questions. We appreciate you taking the time to answer some of them.
Okay, so let's start with Salima. Oh no, that was a direct message, so I won't answer that. I'll answer that privately. Maybe Kaylin. So should
we've collected a bunch, Dr. Dunne.
Oh, okay, you read them too.
So I'll read them out to you, yeah. So one of them you already answered. The next one is, Dr. Dunne, could you comment on ovarian rejuvenation and if there is a clinic in Canada currently offering this service?
Yeah, I mean, I guess it depends what you mean about ovarian rejuvenation. Like there are certainly areas of research. There's a group in Spain that I'm aware of. There's a group in Asia, I believe, centered out of Japan, that are looking at things like trauma to the ovary and taking a piece out and then putting it back in, whether that causes some of the primordial follicles to kick into action or whether stem cells are possible. The answer is that's highly, highly experimental at this point. And to my knowledge, I don't know anybody in Canada who's doing it. Off the top of my head, I can't think of anybody who's doing it in the US either. Yeah.
Okay, thank you, Dr. Dunne. And so the next question is, can you explain why oral hormones are used with IUI versus just OPKs and tracking naturally?
By oral hormones, I think the person might be referring to medications like Clomid or Letrozole, maybe. So it depends on the indication. Clomid and Letrozole are not hormone medications themselves. Hormone medication, Clomid and Letrozole do change your natural hormones by basically creating a surge of FSH or follicle stimulating hormone from your brain. So it kind of kicks a signal out from your brain down to your ovaries to try to get you to make 2 eggs instead of 1. That's the point. And they are helpful on their own for women who don't ovulate naturally. So in PCOS, you might be prescribed Clomid or letrozole just by itself. But if you have unexplained infertility and we're using those medications empirically, they have done a big study that looked at just Clomid on its own or letrozole, just IUI, nothing at all, or both of them together. And the only group that had any benefit was if you put them both together. And that's because there's only a modest benefit from each of those. Like IUI is a small boost and letrozole gives you the extra egg. So that's a small boost. So in and of themselves, they're not significantly helpful, but when you put them together, you do get that small, significantly better improvement above nothing at all.
Okay, thank you, Dr. Dunne. The next question is, if one has an endometrial cyst in her ovary, just small at the moment, 38 millimeters, should it be removed? Does it need to be removed? Should it be removed at some point? And then there was a question about acupuncture supplements, which we'll come back to.
She's probably talking about endometrioma, like a chocolate cyst in the ovary. And the answer is at 3.8 centimeters, I wouldn't remove it. In fact, for fertility purposes, I wouldn't remove an endometrioma at all until the fertility treatment was done, unless it was really absolutely necessary. So when I talk to patients, I say the ovary is sort of like an orange, and the eggs are like the peel of the orange, and the cyst is like the pulp. So if you are going to remove a cyst, then you have to tear the peel. You cannot remove the pulp without tearing the peel. And every time you do that, you damage the ovarian reserve. So I certainly wouldn't do surgery for a 3.8 centimeter endometrioma unless we were worried about it, like it was causing a lot of pain, or you're worried that it might be cancerous or something like that.
Okay, thank you so much. So because we've got Dr. Dunne here, we're gonna circle back to the second part of that question about acupuncture and supplements, and we're just gonna move forward with questions for Dr. Dunne. The next question is, as a family practice nurse practitioner, when do you recommend that she or he refer couples struggling with fertility, even if under 35 and 1 year of trying? This nurse practitioner lives in Victoria, and so always wonders if referring prior to 1 year would help in case there is a long wait time.
Yeah, I mean, the Victoria wait, historically, before we took over the Victoria Clinic, it was very long. I acknowledge that. Now that we've taken over, we're sitting at about, I think last I checked, 8 to 12 weeks. So it shouldn't be too bad. I would say under 35 with normal ovarian reserve and the woman is ovulating regularly, meaning like she's having a cycle every month, 1 year is good. If she's over 35, 6 months, or if she's 40, right away. But if the couple is feeling anxious, or if you have the woman expressing to you that she's feeling like this is having a toll on her mental health, then I mean, we are happy to see people earlier if needed.
Okay, thank you, Dr. Dunne. The next question is, should we wait to get the vaccine until the frozen transfer is done in early May, as we are on estrogen, et cetera, right now, or are we okay to do that right now?
I would get the vaccine whenever you're offered. I think more and more we're seeing convincing data that young people in their 30s and 40s are at risk of contracting serious illness from COVID. And we're also seeing that pregnant women are especially vulnerable. So whenever you're offered, get the vaccine. The only caveat is we ask that you don't get it within 3 days of a procedure. And that's only because it's very common that you get a fever after the vaccine. And we don't want it to be confused with any complications from the procedure. We need to be able to tell the difference between those two things.
Okay, thank you so much. The next question is somebody sharing that they had COVID in November and miscarried in January. And so she's unsure. She was quite early on in the pregnancy when she got COVID. She's unsure if she miscarried from that or just because of her egg quality. So is there any evidence of increased miscarriage rates associated with COVID-19?
That's a great question. I'm sorry that you had to go through that with miscarriage, first of all. I know that's sad news, especially with everything else we've gone through this year. To answer your question, COVID does not appear to cause birth defects. It's not like Zika virus. We can see that there may be a slight increased risk of things like pregnancy complications with preterm birth. Miscarriage specifically, I don't have data to answer your question. So is it possible? Yes, but more likely, most likely, miscarriages are most commonly caused by just spontaneous mistakes or aneuploidy chromosome problems that happen in the embryo. But I obviously won't be able to tell you for sure one way or another.
Okay, thank you, Dr. Dunne. Another question. Can you speak to the stories coming out lately that the vaccine changes your cycle, including some women reporting a loss of their periods for months at a time? Are you familiar with this?
I saw that reported, and there were a couple of colleagues of mine in BC who commented on that story on CBC. I don't think there's any, to my knowledge, biological plausibility to why a vaccine should change your cycle. So I think it's more likely increased vigilance around the time of vaccine to any potential of things that are happening in your body, and potentially like an attributional error to the vaccine versus something else. We know that stress can change your cycle, and that having 1 or 2 irregular cycles in a year is also very normal. So it could just be coincidental.
Okay, thank you. The next question is there any specific lab test or diagnostic tests like an HSG that I can order as an NP within my scope, of course, while they wait for fertility clinic, or do you usually prefer doing all of these tests yourself?
No, and not that we prefer. If you feel comfortable within your scope of practice to order them, then absolutely. Like, I think our medical colleagues should do whatever's in the best interest of the patient. There's different criteria in different cities, where some places that do HSG will only accept the referral from a specialist. So I think in your local area, if you know where they do HSG, like if you're going to send them to, Victoria General Hospital, for example, just call the radiologist there and say, hey, will you accept an HSG referral from me? And usually it just means that you've had the conversation with the patient that this might be an uncomfortable test, and please consider pre-medicating with ibuprofen and Tylenol. And just that pre-test counseling. That's why we stopped ordering the tests preemptively. We only generally order them after we've talked to the patient now, is just so that we have an opportunity to tell them those important things.
Okay, thank you. The next question is, what is your opinion on hysterosalpingo contrast sonography testing, and is it recommended?
HycoC? Yeah, so this question varies by province, and the reason is because in British Columbia, HSG is covered by MSP, whereas HycoC is not. In Alberta, so we don't do a lot of HycoC because it's just patients would rather not pay for that test. Whereas in Alberta, there is a billing code for saline sonogram, and sometimes you can see visualization of the fluid through the tubes. HSG is very accurate at looking at the tubes. HycoC, in some cases, yes, some cases, no. So it's not that I'm not a fan of the test. I think it just varies on like what your particular doctor has been trained in and what the healthcare system in your area covers.
Okay, thank you, Dr. Dunne. Next question, one of my tubes is blocked. Do you recommend unblocking tubes before fertility treatments?
I guess that depends what treatment you're going to do. Like if you're going to do IUI, then you could try a tubal cannulation, which is a procedure like an HSG, where we put not we, but a radiologist, interventional radiologist would put a guide wire through the uterus and into the tube and try to push away whatever's obstructing it, whether that's mucus or whatnot. So you could attempt a tubal cannulation if you want to have both tubes open for IUI. If you're going to do IVF, clearly we don't need your tubes. We're going to bypass your tubes. So in that case, you may not need it. And the only caveat there would be if you're going to do IVF, we want to make sure you don't have fluid in that tube or hydrosalpinx. That we would want to treat before IVF. That was a bit of a long answer, but I didn't know the specifics of the situation.
Okay, thank you, Dr. Dunne. Another question. So we have somebody who's inquiring, her cycle is delayed, so ovulation is delayed. This is something that's common that she notices after IVF, which she did in February. And so is this something that's normal that you see? And then there's a second part to the question asking about vaccines, and I'll just recap from what you said before that that your recommendation is to just take the vaccine as soon as it's offered to you, and just to try to avoid it 3 days before procedure because of the fever.
Yeah, I mean, after an IVF cycles, your period might be a little bit more irregular for a month or two, just as your body kind of goes back to normal. And sometimes some of the little follicles from IVF can hang around as like a temporary cyst, and those can alter things. So it's pretty common that things would be a little bit irregular after IVF. Yeah.
Okay, and so one last question. Is there any benefit to egg freezing if you are not trying to deliberately delay pregnancy? I have noticed some women choosing to do a delayed frozen transfer and saying they'd recommend it over fresh.
Oh, you mean embryo freezing? That's a really individual question because it's very trendy in IVF right now to do an elective freeze-all. There are some clinics, for example, in North America that will do 100% frozen embryo transfer only. I think it depends. If your hormone levels are very high, like if you have hyperstimulation syndrome, then yes, freezing all is recommended. I can say at PCRM, we look at our stats really, really carefully. And it looks like the fresh and the frozen embryo transfers, unless you're hyperstimulated, are very comparable. So fresh embryo transfer is quicker because you get that embryo right away. And you don't have to pay the cost or the time delay of doing a frozen embryo transfer. However, frozen is at least as good as fresh and sometimes better. So if you don't mind doing it, then you can rest assured that the frozen embryo transfer is going to give you at least as good, if not better, chance of pregnancy. So that's really individual. Speak to your reproductive endocrinologist for your individual case.
Okay, thank you so much, Dr. Dunne. Any other questions that you have, we can always maybe fire them by email to Dr. Dunne, and we can forward it back to you via email. So if you do have more questions, feel free to type them into the chat and we'll forward them to Dr. Dunne, and we'll try to get the answers for you as soon as possible. Otherwise, thank you so much for joining us today. It was so wonderful and such a treat to be able to have you here and available and accessible to answer these questions. There's a lot of, there's always so much uncertainty, and there's always so many different ways that this can play out. So it's so great to be able to just have somebody answer everyone's questions. Thank you so much.
Yeah, my pleasure. Have a great rest of your weekend, everybody.
Thank you, you too.